We assess every patient's airway. During an emergency, it may be a quick look at the face. Given the luxury of time, we assess the patient's mouth, jaw structure, throat, and neck extension. How effective is the assessment process at identifying a difficult airway? In terms of sensitivity and specificity, our tests are not that great. Let's review the concepts of sensitivity and specificity. Assume that Mr. Jones has a difficult airway. Sensitivity tells us how effective a test is at identifying his airway as difficult. If the test is 100% sensitive, it will identify the difficult airway every time. If the test is 60% sensitive, it will identify 6 out of 10 difficult airways. Stated differently, the test fails 4 out of 10 times. Specificity tells us the false positive rate. If a test is 80% specific, it will identify 8 out of 10 easy airways as easy, and 2 out of 10 easy airways as difficult. The perfect airway test would have both 100% sensitivity and 100% specificity. Unfortunately, tests lose specificity as they become more sensitive. No single bedside airway test does well in terms both of sensitivity and specificity. On page 755 of Barish's Clinical Anesthesia, we find these numbers. They are a bit disturbing. At best, an individual test fails to detect difficult airways 50% of the time. They are much better at identifying easy airways. Studies indicate that a combination of airway tests should be employed. The Mallampati test fails to identify difficult airways about 50% of the time. However, its sensitivity may approach 80% when combined with the findings of the thyromental distance among the Caucasian population. Unfortunately, no combination of tests has proven satisfactory in terms of both sensitivity and specificity. While a thorough assessment decreases risk, what looks to be an easy intubation may turn out to be quite difficult.